Okay, guys, so this was supposed to be a talk I think my boss was supposed to give, Dr. Moran, so I'll try to do my best in her place. What I'm going to try to do with this talk is sort of start off with a little bit of a historical perspective. I think we need to sort of frame and remind ourselves exactly why do we even give dual antiplatelet therapy. Then talk a little bit about first versus second generation drug-eluting stents is a key concept to understand as it pertains to the benefits or risks of giving longer or shorter durations of dual antiplatelet therapy. Then go into some of the specifics about what are the benefits when we give a lot of long durations of antiplatelet therapy and what are the risks. And then finally, some of the evolving issues that we're dealing with now, most notably, how do you discriminate? In other words, how do you identify those patients who might be the optimal candidates for long durations of antiplatelet therapy? So with that, let me just kind of frame and reorient ourselves with the anatomic space we're talking about. And what we're talking about, of course, is the human coronary arteries. We're talking about putting stents inside these arteries. You all know there are two key complications of these. The first, as highlighted in this cartoon here, is the issue of restenosis. This is really a sort of a response to injury phenomenon. There's a lot of smooth muscle cells. You see the lumen gets progressively narrowed. These patients usually present with angina, uncommonly with myocardial infarction. And this issue was largely dealt with when we got to drug-eluting stents at the bottom, but we traded one issue for another, and that is thrombosis. The issue with the drug-eluting stents is that healing takes longer. So for a longer period of time, you have these metal prostheses exposed to circulating blood and platelets, and therefore you have a nidus for thrombus. And if we kind of look at the last about 25 years or so, I've kind of broken up the last 20 plus years into these three kind of phases. And these phases kind of show you how our thinking from a clinical perspective, a regulatory perspective, an investigator perspective has changed. In the late 1990s, early 2000s, we were focused on mitigating the risks for thrombosis. That was what everyone was interested in. How do you lessen the risk for thrombosis? And we sort of call that the era of thrombosis. Soon thereafter, we realized when we give patients all of these antiplatelets and antithrombotics, we cause bleeding. And bleeding, it turns out, is not so good. It's also bad, and Dr. Moran led the publication, actually, of the Bleeding Academic Research Consortium in 2011. This is the first standardized definition for bleeding. Notice it was only published 5 years ago. And now we're in this kind of different era, which I call equipoise, meaning we recognize that both bleeding and thrombosis are important, and we have to understand how we can sort of prevent one and not incur the other at unacceptably high rates. So let me just kind of go through a couple of these points in turn. So I'm going to take you back to the late 1990s. This is the STARS trial. This trial was done at a time when stenting was just becoming kind of getting out of the experimental phase into the clinical realm, and we did not know what to do with patients with respect to antiplatelets and antithrombotics. You'll notice in this 1,500 patient trial, some of them got aspirin alone. You see the curve here is at the highest, meaning they did the worst. The intermediate here is aspirin and warfarin. So that was one of the regimens we were giving patients, aspirin plus Coumadin. Notice they kind of did intermediate. But look at the bottom line here. This is aspirin and ticlopidine, which is, of course, the precursor to clopidogrel. These patients did the best. It was this observation made in 1998 that informed us and told us that the best way to lower risk for thrombosis is to give these patients two drugs. One has to be aspirin, the other one has to be an inhibitor of the platelet P2Y12 receptor, that being ticlopidine, and of course now we use clopidogrel in most patients. A bunch of other trials around the same time point came out. They showed the exact same thing, and that's what became our current guideline and our current dogma that we still adhere to today. Turns out that if you give these patients these drugs, not just immediately, but if you give it to them for about a year, up to a year, you continue to see benefits. So giving patients two drugs, an aspirin and a platelet P2Y12 inhibitor, is not just good for immediate outcomes, it's good for long-term outcomes. And that's really how we formulated our thinking, again, the late 1990s, early 2000s. At this time, most of the stents that we were implanting were bare metal stents. And most, or some of you will perhaps remember when drug-eluting stents first came out. This was probably in the very early 2000s, 2003, 4, 5. And when these first came out, they were really thought of as a disruptive technology, kind of the way TAVR's being looked at now. When drug-eluting stents came out, they were thought to be this amazing technology. You could put these metal stents in human coronary arteries. There was no longer going to be any restenosis, and we had come up with the perfect way to avoid bypass surgery. You just put in all these drug-coated metal implants, and you're doing wonderful. And at that time point, when we looked at the randomized trial data, we found that there was absolutely no safety signal if you just gave 3 to 6 months of dual antiplatelet therapy. So here you had these stents. You could put them in the human coronary arteries. You could get away with just 6 months of antiplatelet therapy, and you're done. So we thought. In 2006, when the New York Times is publishing stories about cardiologists, it's probably not a good story. And this was when we start to see in the lay press these stories coming out telling us much later after implantation of these first-generation stents, you're seeing thrombosis. So here are patients, and now millions of these have been implanted, by the way, in people all over the world. And you started seeing these reports coming out that were saying even a year later after implant, these patients were having stent thrombosis. What do we do about it? In 2006, there was this huge firestorm. It's been dubbed the ESC, or the firestorm on DES, at the European Society of Cardiology conference, where investigators noted that risks for thrombosis in these first-generation stents were actually higher than bare metal stents. Very concerning, because immediately overnight we had accepted this technology. We were implanting these in patients left and right. Millions of these patients got them. And now all of a sudden, we were being hit with all of these stories in the lay press and in the academic studies telling us that, wait a second, maybe we have caused a major problem because these patients are having thrombotic events. And therefore, in 2007, all of these societies got together. They put out these advisories that we had to adhere to. Notice what it says here, stresses the importance of 12 months of dual antiplatelet therapy. This is why this got hammered in and became paradigm and dogma for everyone around the world that we're still trying to get away from. This notion of 12 months of DAPT, 12 months of DAPT, where all patients really came from these about 10 years ago. So I think it's important to remind ourselves historically where we were, and that helps us understand where we are now and where we might be going. At the same time, we were trying to get our hands around who exactly is getting stent thrombosis. We were putting these in millions of patients, but we weren't having millions of patients having stent thrombosis. It was just a handful. So what exactly causes stent thrombosis? And this is a paper published in 2005, and these results have really borne the test of time. They've been duplicated in many other studies. And the key point here is that the biggest risk factor for stent thrombosis was early discontinuation of antiplatelet therapy. By and large, you'll notice the hazard ratio here is 90-fold, meaning the hazard ratio for stent thrombosis is 90 times higher for someone who stops antiplatelet therapy compared to someone who doesn't. You'll notice these other predictors are important, but the hazard ratios are much less, such as renal failure with the hazard ratio of 6, bifurcation lesions, hazard ratio of 6, and so on and so forth. So here we are in 2005 getting all this information and telling us how important it is for patients to stick to their antiplatelet therapy. And thankfully, not too long after that, we start seeing new generation or second generation stents come about. And this slide illustrates the key difference between the second generation stents here shown on the right and the first generation stents shown on the left. These are histologic sections, so these are cut out of arteries about 6 months after they were implanted. You'll notice on the first generation stent picture, blown up here in the lower left, here is the metal strut. You will see there is nothing above it. What does that mean? That means this metal is being exposed to circulating blood months after implant, meaning these patients are at ongoing risk for thrombosis. If you expose blood to metal, you're going to get a thrombus. Notice what happens on the right. The stents we're using nowadays, the second generation stents and the newer generation stents, you will notice that here's the metal embedded within a nice layer of endothelial cells. And this is what protects us, and this is the whole reason we believe, at least on experimental level, that these new stents are safer, they're inherently less thrombotic, and if they're less thrombotic, maybe we can get away with less or shorter durations of antiplatelet therapy. And if you look at the clinical trial data, this has been published in multiple analyses. This is probably the most popular one, published in Lancet in 2012. And what they did here is they compared cobalt chromium, EES. This is the stent that is implanted in probably 90% of all patients, not only in the US, but across the world. And if you compare the risk for stent thrombosis with this stent platform compared to any other, including, by the way, bare metal stents, you'll notice that the risk for stent thrombosis is substantially less. So all of a sudden, we get these new stents, they've come in, They appear to be much safer. They're less thrombotic, but we've been ingrained with this notion and this fear of stent thrombosis. But with these stents, we finally are able to perhaps take a different picture. You get a kind of more nuanced look at both the benefits and risks of what we're doing with antiplatelet therapy, and that's kind of illustrated nicely in this cartoon. What you'll notice here on the left is what happens to patients after you implant a stent. Again, when we implant a stent, this is a traumatic procedure. There's a risk for ischemic events. You've got to give some antiplatelet therapy. But what happens if you give antiplatelet therapy too long? If you give it too long, anyone in this room knows who's taking care of anyone with coronary artery disease who's got a stent, there is a quantifiable risk for bleeding. So if you give the antiplatelet therapy too long, yeah, you'll lower the risk of thrombosis, you're going to increase the risk of bleeding. So what is the sweet spot, so to speak, right in the middle, where we can expose our patients to antiplatelet therapy just long enough to mitigate risk for thrombosis, but at the same time, not get them into this troubling issue of bleeding? How do we figure that out? And to address those, in particular, what I'm talking about now, of course, are the benefits and risks of dual antiplatelet therapy. We need to understand the DAP trial. So spend a few moments commenting on this. This was the largest trial to date that compared two durations of antiplatelet therapy. One was the control, sort of 12 months, that came from those science advisories back in 2006 and 2007. And the other was 30 months. This was a trial led by industry. It had U.S. government collaboration. This was a major effort to finally answer the question of what exactly is the precise risk and what is a precise benefit when we give these long durations. And here's a study design. All these patients got stents. A year later, they came back. And if they were doing okay at a year, half of them got a thienopyridine. Most of this was clopidogrel plus aspirin. The other half got just aspirin alone. They were followed thereafter to see what happened. So what were the results? Well, here's the main results. What you see here in the green are the rates of events in the patients who got the two drugs for the longer duration of time, and the placebo is on the top. You can see that if you got a long duration of dual antiplatelet therapy, you did better by about 1.5, 1.6%. Not a huge benefit, but it is lower, statistically significant. P-value is much less than 0.05. So the results of this trial make it very clear. And if we look at the individual components of these endpoints, I just want to highlight a couple of things. Stent thrombosis. We're worried about stent thrombosis. People spent their lifetime trying to figure out stent thrombosis. Here in this trial, you see that when you give dual antiplatelet therapy for 30 months, in other words, indefinitely, you lower the risk for stent thrombosis by 70%. I would challenge anyone to try to find anything that we do in clinical medicine that lowers the risk of anything by 70%. Well, here you have it. Here's one example. Myocardial infarction, the other thing that we're all worried about when we implant stents, you lower it by 50%. Notice, however, death, all-cause death, absolutely no difference. In fact, there's a suggestion that maybe death is even higher by 36%. How do you reconcile such large reductions in stent thrombosis, large reductions in MI, but no difference in death? And we'll get to that point in just a moment. But as terms of benefits of extending dual antiplatelet therapy, it's very clear from this slide that you will certainly lower thrombotic events. Well, are there any other patients in whom we might lower thrombotic events? Now, in the DAP trial, the DAP trial was a trial, of course, of patients who got PCI, so they all had metal inside their coronary arteries. What about patients who don't? What about patients who are just in the community? Are there any of those patients in whom you can give aspirin plus clopidogrel, in other words, DAPT, and lower risk for thrombotic events? Well, there was a suggestion. Here's a study. This is a subgroup analysis of the Charisma trial, which looked at over 10,000 patients and basically randomized them to aspirin and clopidogrel versus aspirin alone. And what the subgroup analysis here shows that if you have a history of stroke, a history of MI, or peripheral arterial disease, in other words, if you're enriched with underlying atherosclerotic risk factors, these patients also appear to derive a benefit. Again, a benefit meaning lowering thrombotic events if you give long durations of dual antiplatelet therapy. Remember, there's no free lunch. Any kind of therapeutic intervention that we give to patients, and it's a biological paradigm, if you're going to lower or block one pathway, here we're talking about antiplatelets, so we're blocking platelets, we're going to have some expense, some accounting for that, and the accounting for that is bleeding. So if you look at the exact same trial, the DAP trial, notice I said that the reductions were on the order of about 1 to 1.5%. That's how much we lowered thrombotic events. Well, look at bleeding. We're increasing bleeding by about the same amount, 1%, 2%, 1.5% or so. So while you lower thrombosis by 1 to 1.5%, you increase bleeding by about 1 to 1.5% at the same time. I'm not sure why it's not going forward. Okay. So with these results, on the one hand, we're certainly lowering thrombotic events. On the other hand, we're increasing bleeding. How are we supposed to make a decision? How are you supposed to individualize? How do you contextualize all of this information and try to figure out what you should do for your patient? And whenever we make decisions in the cath lab, outside the cath lab, when we're seeing our patients in the office, inherently, you're thinking about the therapeutic benefit of anything you're giving, a beta blocker, antiplatelet therapy, whatever the case may be, and you're trying to balance that with the therapeutic toxicity. The therapeutic benefit here is lowering MI. The toxicity, of course, is bleeding. So one way one might approach this question is to ask, well, which one's worse? Maybe bleeding is worse, so we should avoid that more. Well, maybe MIs are worse. We should avoid that more. Well, do we have any data to look at that? So these are data looking at the risk of death if you bleed. If you have a life-threatening bleed within 6 months, the mortality rate is 25%. 1 out of 4 people die in 6 months who has a life-threatening bleed. What about major bleed? Major bleed. These are patients who come to the hospital, maybe have a 3-gram hemoglobin drop, they get a colonoscopy, you give them a transfusion, stick around for a few days. These are not patients going to the ICU on inotropes and vasopressors. These are major bleeds. Notice, in 6 months, 10% mortality rate. So bleeding is not benign. It is a very concerning event, even when it's just major in nature. Well, what about the flip side? What about the thrombotic events? This is what we're trying to prevent. What's the mortality risk if you have a stent thrombosis? If you have early stent thrombosis, 1 out of 5 within 2 years will die. Okay? What about late stent thrombosis? These are thrombotic events occurring 30 days or later, 1 out of 10. So both of the events that we're trying to both prevent and the event that we're unfortunately may be causing bleeding are associated with substantial risks for mortality. And if you try to combine the two, these are data from Dr. Moran about 5-6 years ago, and she published this and showed that in fact the risk with bleeding and thrombosis is in fact identical. And we did some more work on this with Dr. Sharma, looking at a whole host of studies, and you can see the bars in the red represent the risk for mortality with bleeds, the blue represent the risks with MI. You can see most of these are right overlapping with one another, indicating, and I think this is something that a lot of us have a hard time sort of inherently accepting and internalizing. When we think of heart attack, when you think of MI, you think cath lab activation, you think of giving them a bunch of drugs, there's protocols we have, and we think these patients are at very high risk for mortality. But when you have a bleed, I don't think you have that same exact urgency, but the data, study after study after study, actually shows that the risk imparted by these events is identical. And so when we have all of this information before us, when we know both of these events are associated with similar risk for mortality, how are we going to make the decision? And this is kind of what we're dealing with now. It is clear that we're in an era of safer stents. It is clear that bleeding is not something we can ignore. And so what we've now, we're sort of in this time period and this sort of paradigm shift now where we're introducing terms such as mandatory period of DAPT. What is the mandatory period of DAPT? Well, the mandatory period of DAPT is defined as the minimum duration that I have to expose my patient to dual antiplatelet therapy to ensure they don't have those early thrombotic events. That's what that means. And this is what we're trying to define. And once we get our patients to that mandatory period, maybe it's 3 months, maybe it's 6 months, we then have to evaluate. We have to evaluate their risk for further thrombosis. We have to evaluate their risk for further bleeding and then make a decision at that time point. This is very different from our thinking just 5-6 years ago when we simply said everyone gets a year no matter what. We're now thinking in a much more iterative, evolving fashion and at different time points. One of the challenges that we face when we're doing this is that the risk factors for bleeding and thrombosis overlap. That's a tough thing, and I think all of us sort of intuitively know that. When we see a patient, you know this is a patient who might bleed. Well, it turns out that's a patient who might also have a heart attack. And you can see the overlap here. A lot of these risk factors do indeed overlap. And so one effort that we've been undertaking here is to try to come up with some individualized algorithms where we can apply to patients and try to actually quantify their risk for ischemia and thrombosis. So here's a risk score we developed, and the key elements are diabetes, acute syndrome, smoking, renal dysfunction, history of PCI or revascularization. And we can count these up and actually quantify this patient's risk for thrombosis. And we can do the exact same thing for bleeding. On the bleeding side, we look at age, we look at a patient's BMI, so very low BMI or high BMI. Again, smoking appears, anemia, renal impairment, and if we discharge them on triple therapy. So we have these integer numbers. We can add these up so you can come up with the risk for bleeding in your patient. You come up with the risk for thrombosis in your patient. And what do you do then? You plot it on a grid like this. So if you have a patient and they're at very high thrombotic risk, in other words, their risk for a future MI seems to be far greater than their risk for bleeding, probably these are patients you should stick with giving them long durations of dual antiplatelet therapy. They're probably the key ones who are going to benefit. Notice at the bottom, the patients who are at low thrombotic risk, these are patients whose future risk for bleeding outweighs their future risk for myocardial infarction. Probably these are the patients who are going to be harmed if you give them long durations, so we should give them much short durations. And our guidelines now, they just got published, actually have changed. It's no longer the 12-month dogma that got ingrained into many of our heads for many, many years. It is now 6 months. And the current guidelines state when you have a non-ACS indication, you put in a drug-eluting stent, you should give dual antiplatelet therapy for 6 months. Now, once you're done with the 6-month period, what the guidelines recommend is to undergo some evaluation, just like what I mentioned, to see if they should get further exposure to dual antiplatelet therapy. So with that, in conclusion, I can say is that dual antiplatelet therapy is certainly mandatory after implantation of a DES, and the reason is to mitigate those early risks for thrombosis that we see. Number two, both thrombotic and bleeding events contribute to mortality equally. I think it's a very important point that many, many people still do not want to accept, but it's the reality. Number three, in this era of safer, less thrombogenic stents, the optimal duration or the mandatory duration now appears to be 6 months, no longer a year. And emerging algorithms and score and stratification tools will further refine decision-making to identify those patients who might benefit from those longer durations of dual antiplatelet therapy. So thank you for your time.